A major problem for the extension of healthcare services to underserved populations is the idea of health as a commodity rather than a human right. Federally qualified clinics may bridge the gap between market forces and altruism. A top example is the San Isidro Healthcare Center, directed by Ed Martinez.
Well, I think the federally qualified health centers, there are 2,400 in the country, all 50 states, take care of 18 million people. They do have developed some standards for quality assurance, information technology, health disparities reduction. So they're working towards an integrated system. They're not there yet, but they take quality care of 18 million Americans, and to me that's a very healthy, robust system.
In 2009, Martinez presided over the inauguration of a maternal health care facility. The gleaming 3-story building houses state-of-the-art medical equipment and a plethora of services designed exclusively for women and their children. Homestead Hospital, a facility committed to medical care for the poor, including immigrant farm workers in Florida, is another shining example. As part of the Baptist health system, it is expected to operate at a loss.
We're so fortunate to be part of Baptist Health, which is a 5-hospital system, and we do lose money every year. We're projected to lose money again this year, and it's our mission. We're there for our community, our patients, and that's what we do.
Dr. Christopher Searles combines work at the University of California, San Diego with a strong dedication to community outreach. His work week finds him on a mobile medical unit at St. Vincent de Paul, at Southwest High School, and at the Scripps Family Medicine Residency Program in Chula Vista.
In order to bring healthcare to the most underserved populations, we have to look at what we're doing now and increase access. At the same time, we need to, I think, change our clinical method once we get patients there. And to increase access, I think we really need to bring in what we're doing well, which are federally qualified health centers, and also the free clinic system, because they do a lot of the heavy lifting.
The system needs to be nonprofit. There is, in the empirical literature, comparing for-profits and nonprofits in almost every part of healthcare, no evidence that I know of that shows that the for-profits have been able to drive higher quality or better efficiency. Sometimes it's comparable, sometimes it's not. There are variations, but overall there's no evidence that for-profit corporate healthcare has been of any benefit in the United States.
The conflict between personal gain or profits and catering to the poor and underserved also affect the decisions of individuals aiming to become doctors.
How do you cope with the undersupply of primary care physicians? Do they all have to come from India? And so can the country not develop some kind of incentive system to move people into primary care rather than simply depend on the moral conviction of a few?
I was teaching residents before, and mainly it was residents from India, Pakistan, Middle East. Probably 1% wanted to be primary care doctors going in. And the ones who went into primary care doctors, they couldn't get anything else. And those are frustrated cardiologists that are not going to serve our populations well.
The drop-off in Latino medical students was shocking, given the number of Latinos that have gone in, finished college, and would have the ability to go to medical school. And I didn't hear an answer as to what that trend is about. But I think it's in many populations and in many ways. Obviously, it's not enough to get a primary care doctor there. It's so important to get a primary care doctor who looks like the patients and can speak to the patient's needs and can speak the language of the patients.
In our experience, we do see a large minority of physician assistants and nurse practitioners that can provide primary health care to the patients.
It wouldn't be a bad idea by now saying to our doctors or our medical students, we're going to pay for your medical school for $200,000 if you are a primary care doctor and serving at least 10 years in an underserved area or something to that effect.
Primary care is key to the improvement of health and the reduction of costs, but several barriers prevent vulnerable individuals from seeking care on a timely basis.
A lot of patients don't have primary care. They come to our facility in very poor condition because of that lack of care. And so we work very hard to make sure that there's good outcomes. But there's a lot of challenges and frustrations because it sometimes is a revolving door. Those patients come back over and over again. And we see that, and you know, we feel that if they had primary care, if they had more continuity in their care, there would be much better outcomes, and it would be a markedly less use of resources. Time is money for them. If they can be making money in the fields to send home to their families, that's what they're going to do. And so if they're well and they feel well, they go to work, and they do. They miss their follow-up appointments. Even if you make that appointment at the clinic, there's a long waiting period to get in. That day finally comes. But if they have that opportunity to make money, they're going to choose that.
Ultimately, the preservation of health does not depend on individual choices alone. Community matters too.
That we can be doing a better job as physicians, but also as communities, to understand our roles in public health and how that we really can't limit ourselves to the exam room and to the point of care, but we need to draw in entire communities and focus on the environmental determinants.
Altruism and a vital market economy need not be at war. Better incentives to support primary care, outreach, and community engagement can extend healthcare services and keep costs down.